So the first speaker this afternoon will be, I think we could say it, El Jefe, Dr. David Notrica, who will be talking about pancreatic injuries in children. David's a native of Atlanta, Georgia, and graduated cum laude from Duke University, and then went on to Emory for his medical school, and did his general surgery residency there as well, so hence the ties to Dr. Feliciano, and went on to do his pediatric surgery fellowship at Baylor, ties to Dr. Maddox, at the Texas Children in Houston. He has a whole host of accomplishments and awards, and is currently in the University of Arizona in Phoenix. He is a co-chair of the Southwest Trauma and Acute Care Symposium, the Western Pediatric Trauma Conference International here, he's the chair of, and the Advanced Pectus course. He's past president of the Arizona Trauma Association at the Phoenix Children's Hospital. He's been chairman of surgery and served on the hospital board of directors from 2005 to 2008. And it's a pleasure to have Dr. Notrica here today to talk about the real deal pediatric pancreatic injuries.
Well, thanks everybody. I really appreciate everyone being here. I'm going to talk to you today about something a little different. We're going to talk about the truth about pediatric pancreatic trauma. And so, as pediatric surgeons, we were taught that children's organs shouldn't be touched. So that was the beginning of the Respect the Spleen movement, which I know a lot of you guys are members of. We as pediatric surgeons think of ourselves as the guardians of children's organs. And only forces of evil would take out spleens. So the same must be true of the pancreas, right? Well, truth number one, the pancreas is not the spleen. So the spleen can be contused, lacerated, lightsabered, but the pancreas can actually be injured in four ways. It can be bruised and contused and lacerated, but it can also have a duct that's partially injured or transected, or a duct that is completely transected. And in patients who have duct injuries, they are prone to pancreatic enzyme leaks. They can get pancreatic pseudocysts. They can undergo autolysis or autolysis of the pancreas itself as it digests not just the fat around it, which is saponification, but actually the pancreas itself. When the spleen is injured, it doesn't really matter that much where the spleen's injured. Maybe the hilum is a little different than the rest, but for the most part, the spleen, you injure it. But in pancreatic trauma, location matters tremendously. For those of you who aren't familiar with grading, a grade 1 injury is shown here. It's a laceration that goes into the parenchyma without any loss. Grade 2 injury is obviously a little bit more significant injury, but again, the duct is intact. Grade 3 injuries are those injuries that have involvement of the pancreatic duct itself. Grade 4 injuries are injuries to the head of the pancreas. And grade 5 injuries are injuries that completely disrupt the head of the pancreas. So, how good is CT at even identifying and grading the pancreatic injury? So, you have to realize that even though we think it's pretty good, if you really look at the numbers, and this is a multi-center trial, a AAST study that was published in 2009 using a 64-channel CT scan, the sensitivity for pancreatic injury was only 47%. And when it comes to pancreatic duct injury, the sensitivity for picking up injuries to the main pancreatic duct was only about 52%. Surprisingly, if they do see a duct transection, it's about 90% specific. And in CT scanning, the dark areas of the pancreas can represent lacerations, hematomas, contusions, or simply fluid. And the duct, despite the arrow pointing to it, is not clearly seen on CT scan. And so truths number 3 and 4 are the pancreatic duct isn't seen on CT, and CT scanning is as good as at identifying the status of the pancreatic duct as a coin flip. So imaging to fully assess the pancreas involves an MRCP or an ERCP if you really want to be able to grade a pancreatic injury. And the CT may be wrong 10 to 40% of the time. So the question is, can some pancreatic injuries be managed non-operatively with good outcomes? And I think we all know that the answer to this, which is that the low-grade injuries, the grade 1 and grade 2 injuries, are very easily managed without surgery. In this study, despite that, these patients actually had operations, and what this showed is that those patients who did have operations, they really didn't do much in the way of manipulating the pancreas. So a lot of these were patients who had operations for other reasons, and they didn't have a pancreatic procedure. And those patients do well, the 1s and 2s. They may have complications, but they don't need surgery in order to heal. So truth 3 is that minor pancreatic injuries can be managed non-operatively. Can pancreatic injuries that involve the main pancreatic duct undergo successful non-operative management? So Dr. Ono in 1995 reported the first pediatric series of a complete disruption of the main pancreatic duct. And it was a case that was successfully managed by percutaneous drainage. And it was really the first reported case. It was a 7-year-old that had a bicycle handlebar injury. They developed a pancreatic pseudocyst, underwent external drainage, and what you see here are the images that are from that article. They did a fistulogram that showed a complete disruption of the main pancreatic duct. They did percutaneous drainage, and it resolved in about 100 days. And what they concluded is that complete disruption of the duct can be successfully managed percutaneously. Here's the problem. This is the image from that, and this is not what a transected pancreatic duct looks like. There's no contrast extravasation, and this is probably a pseudocyst compressing the duct. And this is compared to a picture that I took a few months ago that shows an ERCP. And in this study, and unfortunately I can't point to it, but basically there's a line that shows the duct, and then there's a bunch of black stuff that is actually the contrast extravasation. And that's what a pancreatic duct injury looks like. So following on the footsteps, Kochi looked in 1999 at 5 children who actually had main pancreatic duct injuries, and all 5 developed pseudocysts. 2 of them ruptured their pseudocyst, and 2 of them required operation. The mean hospitalization was about 2 months, and 1 died of sepsis while on TPN. And what they concluded is that non-operative management of pancreatic injuries is effective in children. I'm not sure I would have made the same conclusion. This is a look at the literature, and the pediatric pancreatic studies that have been published. And the red dot is that case report by Uno, and this shows not only the number of cases being reported, but also the number that favor non-operative management. And what you see here is that there is now a vast drop in the number of studies that suggest that we should be doing non-operative management, and that's dropped to 1 or 2 a year now. This study called Is It Worth the Wait looked at 39 grade 3 pancreatic injuries, and they compared the 38 that were managed non-operatively to the 24 that were managed, the 38% that were managed operatively to the 24% that were non-operative. And then after controlling for injury severity scale and associated injuries, the non-operative patients actually had 8 times more complications than those that were managed operatively, and 2 additional weeks of TPN. So what about using other therapies like ERCP to try and save the pancreas? And this is a study that we published last year in the Journal of Pediatric Surgery. And what we showed is that for grade 3 injuries, we were able to manage a fair number of those injuries non-operatively. And by non-operatively, I mean we did ERCP and sphincterotomies. And so there clearly are some cases that we can manage non-operatively. And the truth about those cases is that those that we did choose to manage non-operatively, the duct was injured, but it wasn't transected. So we were able to see the distal part of the pancreatic duct, which means there's a duct injury, but the duct itself still was holding together. And then the other truth, of course, is that if you're going to do that route, healing takes a long time. So ERCP with sphincterotomy and stenting across the duct also shows some promise. Again, the data is very sparse, and I can't list that as a true truth. I can say it as a maybe truth. So does non-operative management of the pancreas save the pancreas? Well, if you do non-operative management of the spleen, you save the spleen. But when it comes to the pancreas, we don't know that you get to keep the part of the pancreas distal to where the injury was. And this study by Edwards shows an injury, which I would point to you, but I can't, and the fact that that all the pancreas beyond that injury has atrophied. Is this common? Well, another study, they had 10 consecutive patients. They re-CAT scanned 9 of them, and 6 of the 9 patients that they re-imaged that had non-operative management, the tail atrophied. So truth number 8. Non-operative management of patients with ductal injury fails to save the pancreas in 2/3 of the cases. Does operation shorten the hospitalization or the complications? Well, there was a nice multi-center pediatric trauma study that was done with 162 patients. 57 of them underwent distal pancreatectomy, and 92% were managed non-operatively. And they compared the groups, and they were comparable for injury severity scale and age and the need for ICU. But the distal pancreatectomy group was quicker to goal feeds by a week, had no pseudocyst, fewer endoscopic procedures, fewer interventional radiology procedures. And so we know that for patients with injuries to the body or the tail of the pancreas, distal pancreatectomy is superior to non-operative management. Can distal pancreatectomy be done laparoscopically? Yeah, absolutely. There have been more than 7 papers now written, and the largest series was about 7 cases where they did laparoscopic distal pancreatectomy. We also published a video of that if you want to see how to do it. It's actually much easier than you think. If you can do advanced laparoscopic surgery, you can definitely do a distal pancreatectomy for pancreatic trauma, especially if they come in early. So when you compare the two groups, open versus laparoscopic, you find that the operative time is about the same for both groups, but the length of stay is only about 6 days for laparoscopic distal pancreatectomy versus about 11 days for open. And the morbidity was not different between the two groups either. So the real question, if you're going to advocate for distal pancreatectomy, is do those patients get diabetes later in life? And if you look at children who have less than 50% of their pancreas resected, they don't have abnormal glucose tolerance testing. But if they have more than 2/3 of their pancreas resected, even though they're not diabetic, they will have abnormalities on glucose tolerance testing. Well, what happens when they're adults? Well, we know that if you look at older patients, adult patients who have distal pancreatectomies, less than 8% of those patients in long-term follow-up will develop diabetes later. And the most common association with that are those that actually had chronic pancreatitis as the reason for having their pancreas taken out or operated on. So what are our options for saving the pancreas? Well, non-operative management doesn't do it, and distal pancreatectomy doesn't do it. Are there any other options? Roux-en-Y pancreaticojejunostomy is an option to save the distal portion of the pancreas. And this is a study of 10 patients, and what they found is that it was equivalent to distal pancreatectomy in morbidity. It avoids pancreatic atrophy associated with non-operative management, and it's a good option in cases where greater than 50% of the gland would otherwise be removed. The other surgical option is pancreaticogastrostomy. And in this procedure, an opening is made in the back wall of the stomach, and the pancreas is sewn into the back of the stomach. This is an image from Hamadan Jarami showing what a CT scan looks like after a pancreaticogastrostomy. So truths number 10, 11, 12. Resection of less than half of the pancreas does not result in diabetes and is unlikely to result in diabetes later in life either. Laparoscopic distal pancreatectomy is surgically feasible when the duct injury is diagnosed early, and surgical options exist for saving the pancreas. Now, last month in the Journal of the American College of Surgeons, another paper came out. And so I added this on later because it concluded that overall, children managed non-operatively have equivalent or better outcomes when compared to operative and delayed operative management in regards to death, overall complications in ICU. Yeah. The problem with this study is that they didn't separate out the patients with duct injuries and without duct injuries. And they assigned the patients who failed non-operative management or had late surgery to the operative group. So what they've done is they've taken all of the non-operative failures and moved them over into the other group for the analysis. So truth number 14, beware of large database studies on pancreatic trauma. And this really has to do with a technical problem where they don't grade the injuries in the National Trauma Database. They use AIS, or Abbreviated Injury Scale. And so they lump together those with duct injuries and those without duct injuries. So the truth, in summary, pancreas is not the spleen. Pancreatic duct is not seen on CT scanning, and CT scanning misses some injuries. Non-operative management of the main pancreatic duct is possible, but it takes a long time to heal. After a week, the abdomen looks like this. Non-operative management of the pancreas fails to save the distal pancreas in 2/3 of the cases. Distal pancreatectomy does not lead to diabetes later in life. Laparoscopic distal pancreatectomy is surgically feasible when the duct injury is diagnosed early. Reconstructive surgery is an option and results in pancreatic salvage. And number 9, the data is poor. So with that, I'll take any questions. Thank you.
Okay, for those online, there in the top right-hand corner of your screen, there's a question mark. So if there are any questions that you have, please just click on that and follow the instructions and we'll try to read them out. Questions from the floor? We have Dr. Ball.
Thank you, that was fantastic. I just want to reemphasize maybe 2 points that you touched on and skirted on. When you run a really busy pancreatic practice, particularly in adults, and I would say in Calgary specifically, we probably see once a month a patient that was managed years before in a conservative non-operative way in the exact scenarios you're saying, that is struggling and has been struggling for years with chronic pancreatitis.
Yeah.
At that point, we operate on them. So I fundamentally agree with you. I think the literature is really not overly helpful because it's all front-end biased. All these patients will go home conservatively managed and be okay for 2 months, 6 months, 2 years, 6 years. But almost always they come back to roost. I think we believe that firmly. The other thing I would caution against, and you showed some beautiful pictures of pancreaticogastrostomies. You also showed hooking up that distal disconnected left pancreatic remnant. Mm-hmm. You know, we do that in elective pancreas surgery all the time in different scenarios, and you probably do as a pediatric surgeon as well. But in general, propagating that, I think, in the literature and in reality is probably a dangerous thing because you're asking a trauma surgeon, on average, who doesn't operate on the pancreas, to deal with a bruised gland, a really small duct, a soft gland, and trying to do an operation they haven't done on a weekly basis. So I think probably, as you point out and as you emphasize, take it out and move forward, get them home, get them better, and get them on with life. Good job.
Thank you. Hopefully that the audience got to hear that because I can't summarize that. But basically what he said is everything I said was true, and and he agrees completely. But he did caution that that not all trauma surgeons can do pancreatic surgery. I think that's sad. David Feliciano told me that, that if you're going to be a good trauma surgeon, you have to be a general surgeon. You have to operate every day. Yes,
David,
Dr. Lacey.
Since the CT scan so poorly defines the pancreatic duct, and since that's so critical in the decision making, are you now routinely doing MRCPs or ERCPs, or how are you addressing that?
So, so that's a great question. So do we routinely image the duct? And the answer is, if the CT scan suggests that there is an injury, then we image them in one of those two ways. And we completely cheat. So those patients who we think that the duct is completely transected, we do an ERCP, and if it shows that the duct is transected, we go immediately into the operating room. We actually do the ERCP in the operating room. If we don't think it is, then we get an MRCP, and if we're wrong, then we take them to the operating room and do it relatively shortly. But we use both modalities. It's a good question.
Any other questions?
Were there any from the audience?
I don't.
Let's see. Enter your questions. It's in Spanish. Okay. Should you screen?
Okay, well, there's one question here, but I might need you there, Felipe.
No, it wasn't. It was an old question. But
Should
still,
you
yeah.
should you screen everyone for pancreatic injury, and if so, who should you be suspicious for?
That's a really tough question. So one of the things that we've learned is that not every patient who has a pancreatic injury has an elevated lipase when they first come in. Most of them will have an elevated lipase shortly thereafter, but no, we use CT scanning to identify those patients with injury, knowing that we're going to miss a small percentage of them. And if they have tenderness or they are not acting right, then at that point we'll get a lipase, and at that point re-image them as necessary.
All right, so now we know we can operate on all viscous injuries and the pancreas in kids.
And the pancreas.
That's it.
All right.
All right.
Thank you.